Well, hello, it's Bruce Williams again, and today I want to present part one of my series on the selected gross pathology of the alimentary tract of the horse. I've decided to break it into two parts because there's a lot of great slides and a lot of great diseases to talk about. As my good friend Fabio Del Piero once said, the horse is simply a gastrointestinal tract waiting to get into trouble. And that holds true, and this lecture, if given uninterrupted, will be well over an hour and a half. So I decided to break it into two parts. We're going to start today with the oral cavity through the stomach. We'll finish tomorrow with the intestine and the colon. But before we get started, I want to thank my good friends and colleagues who, for the last 30 years, have provided me such fantastic images, which allow me to put these lectures together. Well, we're going to start in the oral cavity, and we're looking at the incisors of a young horse. And this is a classic incidental finding that you might see in a young horse, and this deciduous tooth right here has not fallen out. It is called a retained cap. Now, we all know that we age horses by their teeth, and there is a small cottage industry that is dedicated to changing the appearance of the teeth to make an older horse look younger. This practice is called bishoping. There's a lot of things that you can do, including filing down Galvain's groove, which is on the outer surface of the incisors and comes down at a fairly predictable rate, or using silver nitrate to artificially change the size of the cups. This practice doesn't really reverse other signs of tooth age, like the enamel rings that you can count in teeth. But teeth do change as they get older. The dental cup will be gone by 8 years and become the enamel spot. And then there are parts of the pulp which will appear at 8 years in the first incisor. So there's a lot of different things that you can use to tell the age of the horse by looking at the teeth. One other thing the dental cups are actually very good for, and I've used them in cases of acute plant intoxications. So if you think that the animal has eaten or gotten into something, make sure that you dig everything out from the dental cups. They're in the molars as well, and you can often find little bits of plant leaf or something that they've been eating within the last couple hours, which may help you prove that the animal got into a toxic plant. One of the most common dental problems that we'll see in old horses is something that is known as an eorth, or an equine odontoclastic tooth resorption and hypercementosis. It's somewhat similar, at least in my mind, to odontoclastic resorptive lesions that we see in cats. In the horse, you have a combination of tooth resorption by the odontoclasts, which is painful in itself. And then the horse, unlike the cat, will respond with the production of a tremendous amount of cementum as sort of a reparative process, which helps to fill in the defects. But the problem with the horse and the cementum is a lot of times it will go down into the pulp cavity of the tooth and make the process worse. This is a problem that's seen very commonly in old horses. This one's a little unusual because it appears that this disease generally starts in the lateral incisors and moves to the central incisors. This one seems to be most advanced. All this brown stuff is the cementum. It appears to be most advanced in the middle incisors, but usually starts at the lateral. So histologically, these can be very confusing to look at, and you will see resorption of the outside of the tooth, which is partially covered with cementum, granulation tissue, inflammation in periodontal disease, generally lymphoplasmacytic in nature, and you may see encroachment of the pulp cavity by this wave of cementum produced to try to fix some of these defects. There's an excellent article out there in VetPath written in 2015 on these by Rebecca Smedley of Michigan State. I find them histologically very confusing and frustrating. I find teeth difficult to look at. Anyhow, I don't specialize in teeth, but I do recommend that paper, 2015 Veterinary Pathology. Okay, we're looking at severely abnormal wear in the horse, and this is one of the reasons that we have to float horses' teeth. Horses' teeth grow throughout their life, so you want to keep them even. They tend to form sharp burrs on the outside of the cheek teeth, on the inside, or excuse me, on the outside of the maxillary teeth, and on the inside of the mandibular teeth, and these will cut the gums or the gingiva, so we need to keep those shaved down. Other things that you will see in terms of pathology of the teeth is a condition like this where there's obviously uneven wear. This is known in the trade as wave mouth. You can see this sort of wave going on here, and it's seen more often in animals which are grazing sandy soils because it tends to be a little more abrasive, or animals that are on an uneven plane of nutrition. If they're not getting appropriate balanced mineral rations, you can see that manifest in abnormal wear on the teeth. If you lose a tooth, you may develop a condition known as step mouth, where the tooth on the opposing jaw is going to continue to grow down, making it very difficult for the animal to chew properly, and then you will get food impacted here. Animals that have had extractions need to have careful tooth care later on in life to prevent this from forming. So this is wave mouth, and it's subnormal resistance to wear on the molars. We're going to talk about autoimmune diseases mostly when we get to the skin. But there are a couple of generalized autoimmune diseases that affect other parts of the body, and one that we see in horses is bullous pemphigus. These horses generally have sloughing of the oral mucosa and signs of systemic illness. These are pretty. You can see that they're thick. The blisters themselves will last for a bit of time, so you can see them. In bullous pemphigus, the autoantibodies are directed against the bullous pemphigoid antigen, which is a transmembrane form of collagen 17, which is located in the hemidesmosome. So if you damage the hemidesmosomes, that's what anchors the mucosa, the submucosa, and so you're going to get lifting of the entire mucosa off to form the blisters that you'll see in these animals. We don't know why these animals get this disease. In some cases, it's been thought to be the result of drug toxicities, including sulfonamides and penicillin, but nobody's been able to come up with a theory that encompasses all the cases of this that is seen. Another rule out for this, at least from the picture, but not a clinical one, would be nonsteroidal anti-inflammatory overdosage, where you can get ulcers in the mouth of horses and in a number of places down the GI tract. And we're going to talk about that, especially when we get down into the stomach and certain parts of the colon. A potential rule out for that would be an animal that has gotten certain types of grass into its hay, including Setaria or burrgrass. And Setaria are foxtails, also known as speargrass. And they have sharp points with little spikes going backwards. So when the animal gets into this hay and eats it, these foxtail awns will migrate into the gingiva and the mucosa of the oral cavity, resulting in granulomatous inflammation and granulation tissue. And you can imagine how painful this must be for the horse. So this is Another rule out for ulcers in the mouth, and you want to think about foxtail or grass awns within the hay. Okay, we're looking at the tongue of a foal, and foals generally have a hyperkeratotic layer the first couple days of life. They're not eating any roughage. Eventually, as they nurse and as they move on to start eating hay and chewing on hay around the stall, they will lose this particular hyperkeratotic layer. All foals have a bit, and this is probably not outside of the of normal for a foal, but sometimes you can see hyperkeratosis in older animals or severe hyperkeratosis with ulceration, and you want to think about candida infection. You can see candidiasis in concert with various forms of immunosuppression. You can see candidiasis in animals that have been on large doses of antibiotics, a very common cause for candidiasis. And then you can see it occasionally in concert with salmonellosis. We've already talked about severe combined immunodeficiency foals, and if that animal lives long enough, you may see candidiasis there as a result of that immunodeficiency. There is another condition called fell pony syndrome, which is a B cell deficiency. And these animals are lymphopenic in terms of B cells, and you often will see lingual hyperkeratosis and esophageal hyperkeratosis in those individuals as well. Oh, okay. Cleft palate. Palatoschisis is the doctor name for that, and this is due to a congenital defect in which the lingual palatine shelves do not close over the midline. It's a very common birth defect in multiple species, and reports have shown a 4 to 5% incidence, primarily in thoroughbreds, and fairly low in other breeds. It was shown many years ago that this could result from the administration of griseofulvin and other drugs to the mare. Nowadays, if the defect is less than 20% restricted to the soft palate, surgical intervention is often successful. This is one which affects the hard palate as well, and it's going to be a very difficult thing to do. The most common sign that you'll see in these animals is dysphagia. They can't breathe and eat. You'll see reflux of the milk from the nares and the foals. If they get to the point where they're eating any type of solid food, it'll get packed into the sinuses, and it's never a good thing. So palatoschisis, not an uncommon congenital defect. Remember, whenever you look at congenital defects, you want to look at multiple organs, because congenital defects are often like constellations of stars, and they don't shine in just one area. There's usually multiple ones for the person who takes a little time and looks very carefully. It can be very rewarding in terms of documenting congenital defects. Okay, let's move on to the esophagus. And this is a classic focal area of necrosis and hemorrhage, which we call choke. There's often in the acute stages a dilated area with necrosis of the mucosa, often due to ischemia. And then over time, there will be deposition of fibrous connective tissue, which will contract and cause a stenotic lesion in the esophagus. Choke commonly occurs in the same areas in horses, and that's where there's a deviation or a normal narrowing when the esophagus goes over the base of the heart, when it goes through the hiatus of the diaphragm, in the thoracic inlet as it passes by the larynx. So anywhere that it's not a straightaway, you have a predilection to develop choke. There are certain things that commonly cause choke, such as apples or food with a lot of beet pulp in it, or any greedy horse that just bolts his food, including his hay, can result in choke. Also, you want to think about food that's poorly chewed. So in animals that choke, you want to take a very good look at their teeth, make sure that they don't have tooth problems that are contributing to this difficulty in chewing their food. And animals with a lack of access to water are more prone to choke. And we said before that the sequela is often worse than the acute disease. This is a foal with esophageal stenosis. This is proximal here, and here is the stenotic area. Here you can see, obviously, in the esophagus, you can see this as a result of choke. You can also see it as a result of previous ulceration. I'm going to show you some ulcers in a minute in the esophagus. So any damage to the esophagus can result in stenosis and long-term disability. Surgical repair of the esophagus is a very difficult problem due to the very muscular nature and its tendency to break down incisions. So anything is bad. In animals that are hospitalized, and horses hospitalized for choke, there's about a 50% rate of complications, and about 40% of that is aspiration pneumonia, because they can't swallow and they cough stuff and saliva up and they inhale it. So that's a big problem in these animals. And then fibrosis and stenosis would be another one. You can occasionally get perforation and exudation of the material from the lumen into the surrounding tissues, resulting in a severe periesophageal suppurative cellulitis known as phlegmon, a word we don't use too often anymore. You know, it's stressful being a foal. Stressful being a lot of things. It's stressful being a performance horse, and there's a lot of stress in the world. And one of the manifestations of stress, especially in foals, is going to be gastric reflux. And so you get reflux of the stomach acid into the distal esophagus. And look at the ulceration here. There is a syndrome of ulcers in foals, and to a lesser extent in performance horses, where you will get ulcers in the duodenum, which start to set the whole thing off, and those may heal, but due to problems in outflow of food, you get too much fluid and food in the stomach, and you get esophageal reflux. And then if you look at the extensive ulceration, you can imagine how this is going to heal and cause problems that like we saw before. So ulceration, gastrointestinal reflux, and I also have to remind you you have to be very careful with the administration of non-steroidal anti-inflammatories in foals, because if you think they'll do a number on older horses in various parts of the GI tract, including the oral cavity and the stomach and the right dorsal colon, we're not even talking about kidneys, they will really do a number in foals. So gastric reflux, non-steroidal anti-inflammatories, and concomitant ulceration, especially the duodenum, is a problem in foals. Something else that would look very much like gastrointestinal reflux, but this animal is going to have a multitude of other problems, is something we've already seen before when we talked about the cardiovascular system, and this is cantharidin toxicity. Cantharidin is a very potent toxin in a number of ways, and it is a very strong irritant of the gastrointestinal epithelium and the urinary epithelium. And distal esophagus is a very common place for ulceration in these horses. And it's ingested, as we talked before, when these beetles are crushed by hay crimpers and the sacs which the females have are ruptured, then ingestion of as little as 4 grams of these beetles can be lethal to a horse, with a combination of ulceration of the GI and urinary tract and damage to the heart. It gets into the urinary tract and will really irritate and ulcerate the bladder and the urethra, because the toxin is excreted by the kidney. You can also get hypocalcemia, which looks almost like tetanus, with facial spasm and muscle spasms in these animals. So cantharidin toxicosis, or blister beard, we don't see it as much anymore as we used to, but it can be a real problem for affected horses. I suppose one last consideration for ulceration would be grass sickness in horses, or dysautonomia, which is a relatively locationally or geographically selective condition that affects horses in certain parts of the world, and you get damage to the innervation of the neurons, which are present in the innervation of the wall of the gut, become very vacuolated and dysfunctional, and so you have very poor movement of food through the gut. And this is one of the lesions that you see, because the stomach has poor motility, so there's probably reflux, and so you'll see ulceration in the esophagus. Now here's a very common incidental finding in most horses, which is marked hypertrophy of the muscular layer of the esophagus. You can tell it's the esophagus. Look how thick the epithelial lining is, and so you don't want to mistake that for a blood vessel, because the esophagus passes through a lot of feedstuffs. It's very distensible, so it has to have a very thick mucosa. So you can always tell when you're looking at the esophagus. And then you have this tremendous hypertrophy of the circular muscle and this is seen at the distal esophagus, where it gets to the stomach. And in the vast majority of cases, there's no inflammation, there's no fibrosis, and it really doesn't cause any problem with the animal. You see it more in older animals. However, there have been a couple of papers in Frisian horses which have associated this with megaesophagus. One that from Michigan State University that strongly associated with it in 7 cases of megaesophagus in Frisians. They were associated with this finding. A second paper out of Belgium, I believe, said it was only responsible, they could only find a cause of effect for about 33%. So you will see it a lot. Another thing that you can rarely see is a pulsion diverticulum. If you have any type of weakness in the mucosa and submucosa, the tremendous amount of pushing may actually push foodstuffs out of the esophagus. You also see this finding in the distal ileum as well, near the ileocecal valve. Does it represent the consequence of a functional, maybe not histologic or gross findings of an obstruction, but a functional obstruction? We don't know. But do think about, and you may see both of these we're going to look at it when we get to the ileum, but you may see both of these in concert with hypertrophy of the distal esophagus and the distal ileum. So think about it, and if you think about a Frisian horse, you want to think about the possibility of megaesophagus as well. We're moving on to the stomach. We're looking at the stomach. We are looking at the greater curvature, and you should never be able to see what is inside the horse's stomach at any time. This is a gastric rupture. This is almost always seen in adults, and it doesn't mean that the stomach is overpacked and it ruptures. A lot of times, and possibly in up to 50%, what it is you have an obstruction further on down the tract, maybe in the duodenum, maybe in the jejunum, and you build up enough fluid and gas to cause a rupture. So it's not always the food stuff. It's not a common thing in foals. But you have to take some time and you have to look for a predisposing factor. Maybe it's a twist in the gut further on down the line. It results, or anything that may result in a paralytic ileus can do this. So it's often gas and fluid which results in the rupture of the stomach from obstruction further down the tract. Now, these stomachs always split the same way, and old Dr. John King taught us that the first and the biggest rent is in the adventitia and the muscularis, and that splits, and then the submucosal will be exposed, and that will split a little less, and then ultimately you'll get a little bit of rupture of the mucosa, and that is all it takes. It's the last and it's the worst, and when you get food in the GI tract, and that's an endotoxemic animal with a very poor chance for survival. Now, you can also see this as a post-mortem finding, so you want to carefully inspect that wound. If the animal's been sitting around, there's a lot of gas in the stomach, it can blow out its own GI tract. So you want to carefully look at the wound. You're going to see this type of hemorrhage. You're going to see severe congestion of the vessels, and you want to make sure that this is an antemortem event and not a postmortem event. But usually you'll have some history that the animal was colicky or was endotoxemic. You can have, I don't want to say that all of these are due to obstruction, you can have primary gastric dilatation and rupture as a result with overeating too much grain or lush pasture or even water, and maybe only about 5% of these cases fall into this category. Draft horses seem to be overrepresented in the cases of a primary gastric rupture. Things that you want to look at in those cases are going to be maybe signs of pulmonary atelectasis or bloat line, like we would see in a ruminant, where the expanding stomach has compressed all of the blood out of the distal esophagus. And you'll see a very distinct line right there of congested esophagus proximally and very blanched and pale esophagus. So it's a tragic lesion no matter when it's seen, but it makes for very nice explanations. Hyperkeratosis. Remember that the stomach of the horse, this is a normal full stomach, and the stomach of the horse has a squamous portion in the anterior section. This is lined by squamous epithelium. You have the margo plicatus here, which is the junction of the squamous and the glandular stomach. And what we're looking at here is a full stomach has a normal hyperkeratotic layer before it starts to eat a lot of roughage. So you will see some yellowing there, and that's not a problem. Something else that you will see sometimes is that the mucosa will, if the animal's laying around for a while, will peel off. We also see that in ruminants, and people want to jump on lactic acidosis. But if you let a horse stomach sit around for too long, that mucosa is sort of going to peel off. Going to be a little difficult to identify what's going on. Okay, ulcers are very commonly seen in a number of horses. Any horse that is young is very common in foals. We've talked about these. And performance horses, horses that have other illnesses or concurrent disease, you can almost bet that these animals are going to have ulcers. Ulcers in foals less than 50 days, and even in adult horses, are commonly located in the non-glandular region, adjacent to the glandular stomach. We see them along the margo plicatus, along both the greater and the lesser curvatures. If you see them in the glandular stomach, as seen here, you want to think of first non-steroidal anti-inflammatory drug administration rather than normal stress. Let's talk for a little bit about these ulcers in the squamous portion of the stomach. This is one that is a little more affected because it lacks the protective mechanisms of the mucous neck cells of the glandular part. It's thought that up to half of foals under 4 months can have visible ulcers on endoscopy without any clinical signs of GI problem. It's thought that milk provides a buffering action to gastric acid, so foals that have infrequent or interrupted feeding schedules are prone to develop gastric ulcers. If an ulcer is going to rupture or perforate, it's probably going to be in a foal, and studies have shown perforation up to 1% of foals. And when you see those are best diagnosed at necropsy. You can find them fairly easily on the outside. You'll have a discoloration and usually a layer of fibrin over those. Whenever you're necropsying an animal and you think that there is gastric or enteric disease, a quick scan will often show an area of roughening and redness on the serosa, which often corresponds to the area of damage on the inside. If we look at these glandular ulcers, remember that this is probably due to nonsteroidal anti-inflammatory drugs. There are certain parts of the body where the vascular system, in order to maintain patency in the capillary bed, requires a constant infusion of PGE and prostaglandin E2 and prostaglandin I2, and the COX inhibitors, or the prostaglandin inhibitors that are common pain relief medications, will cause ulceration in, as we've already said, the oral cavity, the esophagus, the stomach, especially in the glandular part near the pylorus, and then also in certain parts of the colon, especially the right dorsal colon. In addition, nonsteroidals will also decrease bicarbonate secretion, which of course has a buffering mechanism in the stomach and has direct toxic effects on the vascular endothelium outside of prostaglandin, where it inhibits nitric oxide secretion. So, and these, as you can imagine, this location can result in, when it heals, a constriction and diminished outflow from the pylorus. So gastric ulcers, a big problem in many different types of horses and different ages of horses, and something that we need to be constantly vigilant for when dealing with horses. Well, we're back to a severe toxin, and this is our old friend cantharidin toxicosis. And you can see here in the stomach that the mucosa is just absolutely peeling off. You know, they used to use the terpenoid cantharidin from blister beetles to medically to remove warts in people. So it's a very toxic substance. Bots. Okay, bots are common. A lot of animals had bots. It's not as common as they used to be, but a lot of people will have bots. These are the larval forms of flies of the species Gasterophilus. The two common ones are Gasterophilus hemorrhoidalis, which generally congregate in the air pocket closest to the fundus of the stomach, and then you have Gasterophilus nasalis, which congregates in the air pocket of the pylorus. They have to be above the waterline, so to speak, to survive. So they tend to colonize in the same spot anatomically, and people for many years thought that they didn't cause any problem because they were so common. They don't cause a whole lot of problems, but they do because they latch on. They will result in ulceration, very rarely perforation, and a marked hyperkeratosis in these areas, and the ulcers that they leave can become secondarily infected. I'm not going to say that they are a tremendously pathogenic. They tend to be a pretty good symbiont, but they do cause problems. So the people say they don't cause any problems. They're probably overstating their case. And remember, Gastrophilus is a fly which glues its eggs to the hairs of the forelimbs and the shoulders. So when the animal licks them, the larva will hatch, and they will crawl into the mouth, and the larva embed in the tongue for a month or so, after which time they pass to the stomach to attach themselves into the cardiac or the pyloric portion of the stomach. What I always found a little odd was the naming of these, because Gasterophilus duodenalis is not the one that embeds close to the duodenum. It's the one that excuse me, I got that wrong. It's Gasterophilus hemorrhoidalis is the one that embeds anteriorly in the cardia of the stomach, and Gasterophilus nasalis, you would think, would be the closest to the nose. That's the one that's the farthest away. There is a duodenalis as well, and I can't remember where that one particularly embeds. But I always thought the naming was sort of interesting. And then, you can see a little bit of stomatitis or periodontitis from the tracts that the larvae leave in the mouth, around the tongue, and around the gingiva as they migrate to the stomach. So, and here's the picture. I'd forgotten I had this one in here, but we're looking at these shallow gingival ulcers, which are the migration tracts for the larva. What a great picture. And here are just a couple more, and you can see that the place where they embed, the mucosa is devoid of rugae. It is probably hyperkeratotic, which would make it more susceptible to damage by gastric acids. So not something we associate with a lot of pathology, but not something innocuous either. Oh, the parasites of the equine stomach. There are a number of them. They often show up in groups, but some of them at least more photogenic, are spirurid nematodes belonging to either Habernema, which causes lesions both in the skin and mucous membranes as well as in the stomach, and Drachia. What we're looking at right here, very characteristically at the margo plicatus of the stomach, is a large granuloma, also known as a brood pouch, of Drachia megastoma. I like that name, megastoma, for big mouth, and I think that's what this is describing right here. It is a granuloma, but there are live Drachia females which live in there, and they lay their eggs through this hole, and they go out in the feeds. The eggs or larvae of both Drachia and Habernema, which are helminths, are ingested by maggots of flies, either house flies or stable flies, which serve as the intermediate hosts. And these flies are attracted to moist areas of the horse, so you'll see them around the eyes, you'll see them around the external orifice of the genital tract, maybe around the penis, around the lips, anywhere where the fly can get a little bit of moisture. They will deposit the larva of Drachia or Habernema. Habernema, and when we get to skin, we'll talk about summer sores, but they very characteristically, if they don't get into the GI tract, then they will burrow into the skin and die and result in a eosinophilic inflammation in the areas where the flies congregate, which are known as summer sores. The horses are generally infected. They get the gastrointestinal infection by swallowing the larvae, which are walking around as the flies are feeding on the lips of the horse or getting their moisture from the lips of the horse. So if they get into the GI tract, they will go through their lifespan and do what they have to do. Otherwise, they may burrow into the skin and cause a immune or an inflammatory response. The horses tend to tolerate these. They may have 1 or 3 or 4 of these. They rarely can perforate. Sometimes these worms get a little too active and they will perforate through the other side and result in a fatal peritonitis. And there have been a couple cases in which there have been enough of these to cause mechanical obstruction of the stomach. That's Drachia. And you have to look a lot closer for the adults of Habronema, which live also in the mucosa at the margo plicatus, but don't form the brood pouches like Drachia do. Another helminth parasite that we see in the horse affects the glandular stomach and is a trichostrongyle. Tricho meaning hair-like. So they're very small strongyles. Well, I shouldn't say it. I'm going to say the trichostrongyles. And I won't say the term small strongyles because we're going to look at that in the next lecture. That's something very different. These trichostrongyles belong to the genus Trichostrongylus. The species name is Axii, and they're well known for causing a hyperplasia of the mucosa of the glandular stomach. They're very similar to Ostratagia in ruminants. And you get this nodular, somewhat, it's been referred to as Morocco leather appearance to the stomach. Now, one of the interesting things is Trichostrongylus axii is thought to be a parasite of horses. And it is, and it causes the most severe lesions in horses, but it's actually a cattle stomach worm. And you'll only see this if you are running your horses in with your cattle, or you are letting horses graze where cattle graze, because there's always a cattle or history of cattle being grazed on a particular pasture where the animals have Trichostrongylus axii. There's very little inflammation associated with this or the other trichostrongyles. They tend to live basically on the surface of the mucosa, and the irritation that they cause, the wiggling and jiggling and tickling inside them that they will do on the mucosa, causes a proliferation of the epithelial mucosa, and you get these sort of waviness and ultimately the nodule formation. You see some of the same clinical signs that you will see in a ruminant with a severe case of osteoarthritis. You see, because the mucosal epithelium is proliferating at such a rate, it really doesn't have time to set down the normal desmosomes and form an intact barrier. So these animals will lose protein. They will become hypoalbuminemic. You'll also see elevated levels of pepsinogen or hyperpepsinogenemia, because the pepsinogen, which is normally in the stomach lumen, has the ability to be absorbed through this non-intact mucosa and get into the bloodstream in higher levels than you would expect. And these animals obviously are going to be wasting. So no inflammation. This is an epithelial mucosal hyperplasia. It's not an eosinophilic gastritis like we might see with Drachia or granulomas. So, but Trichostrongylus axii. Okay, and finally, we're going to end up with a common neoplasm in older horses. Please ignore the bots; they're not doing anything. But we're looking at the stomach of a horse. This is probably a pretty wasted, skinny horse. And here's the margo plicatus. And when you look at the squamous epithelium, it is lumpy and bumpy and fissury. And whenever you see the stomach of a horse and it looks terrible on the inside, you're probably dealing with gastric squamous cell carcinoma. Obviously, these are going to arise in the squamous portion of the stomach, and they look terrible because of a number of things, including they produce keratin, and the body hates keratin on the inside, so you're going to have a tremendous inflammatory response. There's often a desmoplastic reaction, and these neoplasms are known for a number of things. One is that they will cause hypercalcemia. In a horse, it is one of the many causes of hypercalcemia, sort of a paraneoplastic reaction to the presence of this tumor. They can metastasize widely, or they can explant along the surfaces of the intestine and along the abdominal serosa or peritoneum. So I think that covers most of the good diseases, but certainly not all of them, of the upper alimentary tract. At this point, we're going to cut loose at 45 minutes, and when we come back, we're going to start with the small intestine and the large intestine, and we will finish up the alimentary tract of the horse. I hope you enjoyed the lecture, and I hope you will come back often to the Foundation's YouTube channel or the JPC's video library to view more on horses or many of the other species. As always, I wish for you wonderful health and that you'll have a fantastic day.